the test techniques on how you can dissect these stuff really quickly, depending on what you see that is or is not present, right? Presents with a family with a history of dysuria and suprapubic tenderness. All right. Now, she denies fevers, chills, nausea, or low back pain. So, without even getting to her vital signs and objective data, what do you think she has? A cystitis, a bladder infection, right? There you go, all right? And then we go down farther. Sexually active, stable, monogamous relationship. We always talk about STIs as a big crossover for differential diagnoses. Physical exam unremarkable. Unremarkable except for mild suprapubic abdominal tenderness, right? Is that going to be common if you have a bladder infection? If you have infected urine, is it going to hurt when you press in the bladder? Yep, right? But unremarkable meaning what's absent? In this case, yeah, systemic symptoms, but in this case, specifically CVA tenderness is not present, right? So there you go. Vital signs within normal limits. Bam. Now what do we get to? Huh? Charlie, nitrofurantoin, right? Okay. Ceftriaxone, IM, don't need it, right? Not going to work, and it's also not for this, right? It's also not going to work. It's not indicated for this patient. Cipro, we talked about. There has to be a real compelling indication why you give her a fluoroquinolone, right? If I made her allergic to everything else. Levofloxacin, again, same thing. So if Cipro is wrong, Levo is typically wrong too, right? Pair those out. And then urinalysis and follow up in 7 days. Do we want to let this cook for 7 to 10 more days? No. Okay, easy, right? Those are straightforward questions I hope. Differentiate, right? Which one makes it different? Huh? Delta? Yes, right? Dysuria are both going to hurt when you pee? Yep. Hematuria? Probably? Yep. Or even if it's not present, absent is going to help differentiate? No. Pyuria? You expect white blood cells in the urine for both? Yes. And then urinary frequency we talked about yesterday. That's one of the common cardinal symptoms of it. You got to feel like you got to go to the bathroom all the time because that bladder is irritated, and urinary frequency is an irritative voiding symptom, right? And so we get down to CVA tenderness, which manifests as, like you got a gentleman over there said, systemic symptom, right? Simple, uncomplicated cystitis. Consistent, not consistent with, right? We look for not. Not. Which one? Delta. Leukocyte cast, right? If they have leukocyte cast, what do they probably have? It's pathognomonic for blank. What is blank? Pyelo. There you go. All right. You guys remember? It is 6 weeks. It's 6 weeks. Remember the first time I ever gave a test, I got up and I did this big speech about how I'm not trying to trick you and I promise there's only one right answer. And deployed the test, started, and like 2 seconds in, poof, everybody's hand went up. And so like one of the choices was 3 months and another choice was 12 weeks. And like, I didn't say I was strong in math, y'all, I'm sorry. So. All right. Ulcerations of the bladder? Someone already said it. Hunter, right? Hunter lesions, Hunter ulcers. Those big, ugly looking things, right? And what are the glomerulations, you guys remember? The cracking of pinpoint bleeding, right? That sort of capillary, if you will, type of, right? All right. Wonderful. So, kidney stones. What do you think the mainstay, like literally the mainstays of our treatment for patients with chronic kidney stones are going to be? Hydration, I heard it out there. Yes, pain control for sure. Pain control and hydration. Hydration is going to be the big one, especially for our chronic kidney stone patients, right? They need to drink enough water to produce at least 2.5 liters of urine a day, so they need to be peeing frequently, all right? Does anybody want to take a stab at kidney stone formation, like the chemical formation, like what happens real fast? Huh?
Calcium carbonate.
Yeah, those are the components, but I'm talking about just general chemistry, right? What do you think makes a stone form out of solution? What makes something aggregate out of solutions? Saturation. Saturation of the solute, right? So if you have a supersaturation of the solute, meaning you have a high concentration of this stuff dissolved in the liquid, it is more likely to aggregate together and create a stone. And that's literally the principle of how kidney stone formation happens, how kidney stone formation happens, but that also is how we attack it, right? So we can give things that inhibit stone formation, or we can give things that reduce the concentration of the solutes to inhibit the process as well, right? So two different ways we can attack it, and then one thing, the overarching thing that we just talked about is water. Because if the solvent is greater in concentration, right, we have more fluid, then it thins out the mix altogether, right? If you have so much stuff in a vessel, and you pour a bunch more water into it, it's thinned out. So we also help prevent stone formation quite a bit with water, which again is a lifestyle change, which again becomes one of the hardest things to get our patients to do, right? Anybody, I don't know, this example keeps getting older and older with me, but has anybody ever seen when you were like in high school chemistry or like earth science or something like that, where they put a beaker of fluid on like an overhead projector or just in front of you where you could see it. Overhead projector used to be things that would project things overhead. So, yeah, I know, shut up. So, anyway, so the solution is clear, right? And then the instructor puts one more drop of something in and it becomes completely opaque. You ever seen that experiment before? Yeah? All right. That is literally kidney stone formation, but that's happening in your kidneys, right? I like that example because it makes you feel old. All right. So, kidney stone disease, again, just a matter of where is the stone, urolithiasis, stone anywhere in the tract, nephrolithiasis, if it's stuck in the kidney, is it really important to be that precise? Nah. But just in case you understand, you see these terms as you're reading journals, reading texts, what have you, we understand that there is a minute literal difference. But overall, we're just talking about urinary stone disease as the comprehensive process, okay? Again, why does something as relatively simple as urinary stone disease have its own lecture? Because you guys are going to see it all the time, right? This is not the nephrology section. This is the stuff that happens really all the time in real life, all right? Not just on the pants. So it is prevalent. Basic pathophysiology, we already talked about this. That's why you guys have it. But think about some of the other components, right? Not so that we have the supersaturation of the solute in the solvent, right? We have too much stuff dissolved in the urine. What are the things and factors that contribute to that? Not drinking enough water, which leads to reduced urine volume. But also, what else that we could put patients on would lead to potentially reduced urine volume? And diuresis, diuretics, right? Exactly. So we have a potential crossover. So understand all of the things that happen with reduced urine volume. Alterations in urinary pH, I tell you, we don't look at that a lot. Remember we talked about that, how we don't really pay attention to that? This would be the only sort of milieu where we pay attention to it, if we have a chronic stone former. And really, even in that, the only one where it really we pay attention to it a lot would be two different kinds of stones. And one, somebody said uric acid, and then struvite stones, which are chronic kidney infection stones. And we'll get to that. But really, even that parameter is not entirely super useful. But again, if we're going to be looking at labs, this would be the time when we pay attention to your urinary pH on that anyway, all right? And so we don't need to beat this to death, but we have too much stuff. It forms a little nucleus. It gets bigger, growth, that's what that means, and it aggregates and becomes a stone, okay? So this is a picture of that. Right? So when we get down here, we have more than enough. We either have enough of the solution, meaning enough water generally in our urine that we're not able to form stones, or we don't have enough stuff dissolved in it as we go in less and less urinary or higher urinary concentrations. Then we override the ability. We have inherent protectors of stone formation, something called cysteine, right? And if we don't have enough of that, then we lose it, all right? Or citrate, not cysteine, citrate. Forgive me for that. citrate. We have citrate in our urine that helps prevent stone aggregation, stone formation. If we don't have enough of that, then this can also create this mechanism as well. And if I haven't beaten this to death yet, if you have too many red dots and too many black dots, then they form a big rock in your kidney. Okay? All right. Imagine urinary flow, right? Essentially dripping down, right, the renal papilla. Not really, but that mechanism is essentially where it filters down the renal pyramids into now the tip of the renal papilla right there, and then urine flows out into the calyces, right? So I like to think of it sort of as like a stalactite, right? So you can end up having stone formation sort of at the tips of these renal papilla, and then eventually they can break off and become a loose stone. All right? Is any of that really that important? No, but that's how stones form. It really is important. What's important is the basic. You understand the basic mechanism. And why is it important that you understand it? Because you're going to have to explain it to your patients. Why do I keep getting kidney stones? Well, if you would drink water like I told you to, this process wouldn't happen. If you take this medicine that I prescribed to you, instead of taking it once, taking it like I gave it to you, this wouldn't happen. If you would exercise more, so you see what I'm saying? The more patient education you can offer because of your understanding of it, the better that patient is, and the more likely they are to actually physically do what you're telling them to do because they understand why they need to do it, all right? So, do you think kidney stones are common in the San Antonio metropolitan area? Yes. They are. A slightly high protein diet, high salt diet, high humidity environment, right? It's 89 degrees on Christmas Day. Yeah, there's going to be a lot of kidney stones, okay? So, again, acidic urine and alkaline urine. Again, this is still relative. We're not talking about the extremes like way over here. It's just differences, slight differences in acidity will lend itself for something to precipitate out of solution, all right? So uric acid tend to precipitate in acidic urine. And Proteus species, we're going to talk about struvite stones here in a minute, tend to come out of solution in a alkaline urine. But even that, let me tell you that when you're talking about urinary parameters that are semi-useful, what else would give away that this patient has uric acid stones? The fact that they have gout, right? So, you see what I mean? Or the fact that they are currently on chemotherapy for some sort of malignancy that's causing uric acid release when the chemotherapy regimen occurs, right? And just to give you away, like UTI from urease producing organisms, right? So if you have alkaline urine and you have struvite stones, the other key that's going to give it away before urinary pH does is the presence of frequent and recurrent urinary tract infections, right? So again, limited use of the parameter, but I just want to call it attention to it. So you know that this is something that you can use if you were completely stumped. Maybe that's the thing that helps you go one way or the other about why this patient continues to form stone, right? So stone composition, I know we're not chemists here, and I know we're not going to be the ones who are crushing up these stones and looking at them in the lab, but the PANTS and the PACRAT do like to ask you composition questions, so we're going to cover composition, all right? I can tell you all on here, the most likely one you're going to see is calcium oxalate. That's why it's at the top. That's probably going to be 85 to 90% of the stones that you encounter in clinical practice, okay? So, look at the risk factors here. Okay. Dehydration, and that's relative, right? So relative low urine volume. Somebody doesn't drink enough water, essentially. High sodium and animal protein intake. Okay. And hypercalciuria, we're going to talk about in a minute. Now understand, not hypercalcemia, even though that will, of course, hypercalciuria. So there's too much calcium in our urine, right? And that goes all the way back to the first thing we said. If there's too much of the stuff that makes the stone in your urine, their stones are more likely to form, right? And so we can affect change for calcium oxalate stones by doing what? Giving a medication that would do what for this patient? Reduce the calcium in the urine. And luckily there are medicines that do that, okay? And then urine citrate Okay, I'm going to get to what that is, but again, I mentioned it is an inhibitor of stone formation. Okay, so the other thing, right, if we can give a medicine that takes calcium out of the urine, what else do you think we can do for a patient who has low urinary citrate? Give them a medicine that adds citrate to the urine. Exactly, right? It isn't rocket surgery, right? And it's radiopaque. Why? Because there's a calcium component, right? The overarching theme is, you guys already know this, I hope. What is the standard radiograph for somebody with a stone? Huh? No, not a KUB. All right, a KUB is useful if you don't have a CT scan. Non-contrast CT scan is what you need to get because it'll see all of our stones, right? There are radiolucent stones, so there are stones that you can't rule out even if you have a KUB, because a KUB, you know, it won't see those stones. It might look like a stone, it might walk like a stone, but in order to really definitively rule it out, you need to get a CT scan. Can you also use POCUS? Yes, you can. All right, but the standard, like if you're going to answer a question on a test, standardized test, that's what is the standard of care, is a CT scan, right? Okay, so calcium oxalate stones. The back half of this calcium stone is oxalate. What is it? It's a digestive breakdown product, okay? What usually happens with calcium oxalate is there's sufficient calcium, dietary calcium in the gut, right? Now we're not talking about the urinary tract, we're talking about in the gut. That gut binds to the oxalate in the gut, and then it comes out in feces, right? If you don't have enough calcium or you have too much oxalate, what happens then? Essentially, the mechanism is that the oxalate makes its way back into the urinary system, winds up in the urine, and then it makes stones. It has a high affinity to bind with calcium in urine. Does that make sense what I just said? Okay? So, strongest promoter of stone formation. This I bring up because I have a spouse who refuses to stop drinking Emergen-C. Even though I told her to stop drinking Emergen-C, she won't stop. So I hope she doesn't get kidney stones. But if you have somebody that you know that does get kidney stones and they take a bunch of vitamin C, tell them to stop because they're literally pissing their money away. Why? Because what's the solubility of vitamin C? Water soluble. So where does all that extra vitamin C go? Toilet. So you know. All right. All right. Any questions about oxalate stones? We're going to get more to how you prevent oxalate in the dietary measures and later on. But does any general questions? Pretty straightforward. Most common type of stone, due to too much calcium, too much oxalate in the urine, and then we'll get to treatments in a minute. All right. Calcium phosphate stones, very much similar. Okay. Anybody remember this little guy right here? RTAs. The one that forms stones. These are the stones that form for those patients, all right? You can see them for other reasons, definitely other reasons, right? MSK, remember medullary sponge kidney, those ones too, a bunch of little stones. Similar, very similar risk factors though, right? Sodium, protein, dehydration, hypercalciuria, and then low urinary citrate. And then citrate, it's an inhibitor of stone formation. Okay, it binds to the calcium and takes it out of solution, right? When it binds to calcium, it doesn't form a calcium citrate stone, it takes it out of solution, helps it wash out and be excreted rather than sit in solution and form stones, okay? So again, we can use this as a supplement medication that we give our patients in order to prevent and inhibit stone formation. Okay, and you see this one right here. That's why renal tubular acidosis, that's why the stones form, right? Acidosis leads to reduced urinary citrate. So if we're losing, because of the acidotic state, we're losing that urinary citrate, we have more calcium available to bind, and so we have stones. That's what the stones form in RTA. Okay? Struvite stones, if you're going to put this down in your brain, put them down as infection stones. Have you guys heard of staghorn calculi up to this point anywhere? The calculi that fill all the calyces, those big, ugly looking like moose stones, yeah. That's what these are typically. Now, you can get staghorn calculi from other etiologies, and they're almost 90+% of them are because of struvite. And the struvite stones are almost always because of infection. So that patient, again, I referenced it earlier, will have a history of recurrent or frequent urinary tract infections, most likely, right? Proteus is our friend, most common. And then again, you have these big staghorn calculi, right? Almost always struvite. Okay? Uric acid stones, again, these are going to be our two primary patients, gout, chemotherapy patients, somebody with it being treated for a malignancy of some type. Right? Why chemotherapy? Because its job is to destroy the cancerous cells. When it destroys the cells, it releases the nucleic acid material. We have too much uric acid, and now we have the capability to form stones. Okay? Maybe look at this little guy right here. That's why KUB isn't the right answer as far as like ruling out definitively kidney stones. Okay? On ultrasound, it'll give a shadow. You'll be able to see it, but again, don't get that in your head. Standard of care, CT scan, non-contrast CT scan, okay? Cystine stones, now these are our zebras in our kidney stone family because every family has to have a zebra. It's an autosomal recessive disorder, which is what? Inherited. So where would you maybe find stones in this patient population if they're inherited with a preponderance to make kidney stones? Males, yes, but what size males? Small ones, yes. Children, right? Children with kidney stones, normal? No. Then you would think this is some weird. You would stumble onto this, all right? You're not going to probably think it unless it's known in the family history or unless genetic testing was done and you already established that it's going to be something that you kind of stumble onto. But if you ever see somebody, a child, a teen, that has started to develop kidney stones, that's sort of out of the realm of normal, right? And so definitely work that up. But again, what's the easy button answer of how you would find that it's a cystine stone? Does anybody know? What's that? No, I think you're right. What'd you say? After they pass it, you catch it, and you send it to the lab, and the lab tells you it's a cystine stone. You're exactly right. And that's the importance of getting when we talk about workup and diagnosis, catching the stone so we can get a legitimate composition analysis from the lab. That tells us exactly what it is. All right. Okay, any questions about compositions? Straightforward, right? Calcium, uric acid, struvite, cystine, weirdo, right? Okay, patient presentation. We talked about it yesterday, and you guys were dead on. It's a patient who's probably usually, like that, write that down. Probably moving around trying to find a position of comfort. As that colicky pain, that wave, it hits them, they're like they just can't sit still. Like they're going to be dancing around a little bit in general. And what causes the colicky pain? Huh? Movement of the stone, or what else? Okay, you could say spasm, but really what we're talking about is think about urinary peristalsis, right? As we're moving the urine towards it, it moves and it just bumps up against that stone, right? Whether it moves or not, that causes a pain, because remember the renal capsule encapsulates the kidney, so it just stretches like, ugh. So you get that wave of pain, right? And this patient isn't going to go colicky pain like they're going to go from, they're going to go up to 10 and then down to 0. They're going to have a baseline, like, yeah, I'm in pain constantly with spikes up to whatever. Okay, make sense? And this one is good, right? Stone size does not correlate with symptom severity, right? That patient has a staghorn calculi forming. They might have minimal symptoms. If you got one of those sharp pieces of rock ripping through your ureter, even if it's 4 millimeters, it's probably going to hurt you pretty bad. All right, so not really able to put a 1-to-1 correlation. And again, good job. This is the last slide, renal colic and non-colic pain. So they're going to have that stable pain, right? Either from the stone movement or from the the peristalsis of the urinary flow, or they're going to have that sort of hydronephrosis pain, distending the renal capsule. So they're going to have like that baseline constant pain with sharp increases. Okay. CVA tenderness. Why? Because that's where the kidneys are. And if you have a kidney that's already angry and you punch it, it gets angrier. All right. What you will typically see as a radiation pattern, this is fairly pathognomonic as well, is pain radiating to the ipsilateral labia or scrotum, hemiscrotum. Okay. So if they have that patient, you know, it's sort of like down back from around here down into the groin. That's a pretty pathognomonic pain radiation pattern. Okay. Patient may also complain of abdominal pain. I mean, it really does. Sometimes it depends on where that little guy is in the movement down and out. Right? So the pain may eventually just sort of manifest as just abdominal pain. So again, keep that in your differential diagnosis of abdominal pain. Generalize it out. Don't forget about kidney stones. Everybody thinks about the stuff in the front. Don't forget about the stuff in the back. Right? And again, that pain radiation pattern sort of wraps around and then comes down, irritating the genital femoral nerve. Patient presentation, let's talk about places where these things can get stuck. All right. Ureteropelvic junction, where's that? That's right where the kid, yeah, and we're talking about the renal pelvis, not like the anatomic pelvis. So the renal pelvis, yes. Right? This is a stone that gets lodged right as it leaves the renal calyces, right in the collecting system. So what is a potential sequela of that? It's already on here. Like if it's obstructing that stone, if it's getting stuck and lodged right there, what's not being able to flow past it? Urine. And then what's going to happen? We're going to start to see the relative hydronephrosis form pretty quickly. Right? Ureterovesicular junction, where's that? Bladder. Yep, right at the top of the bladder. Again, there's that anatomic sphincter we talked about with a vesical ureteral reflux. This time something's trying to get in. Because that little sphincter is there, it's a common place for a stone to get wedged. Okay? This is a very specific radiation pattern that patients will complain of. It said like you're going to say it hurts like at the tip of their penis, especially when they try to urinate. All right? But again, ureteropelvic junction, this little guy right here, real risk of hydronephrosis. Risk of hydronephrosis if a stone lodges anywhere. But again, if it's right at where the urine is trying to escape, then it's going to form pretty quickly. And then vesicular junction, less commonly, any place where they have an obstruction or a bump it has to go over. So if it's going over the iliac vessels, if that's a bump, it could get stuck there as well. Less common than at the other two sites. Okay? Questions so far? Good. Differential diagnosis, belly stuff. Okay? I know that's very generic, but you know what I mean. Anything that's going to cause pain from here to here should be in your differential diagnosis. Now, I'm going to say it now and again. If you add a fever onto that, that's really one of the things that makes a kidney stone an emergency. Kidney stone and a fever. So a lot of these things are febrile states, as you can see. But even if the patient has a fever, definitely don't rule out kidney stone until you've worked it up and ruled it out sufficiently. Because if you do have a kidney stone and a fever, that patient needs to go to urology to get that stone out, like now. Okay? Don't forget this, right? Somebody has a frequent kidney stone, or people know, it's less common now because we are a lot less judicious with our narcotics than we used to be. But people may use kidney stone as drug-seeking behavior, right? So. Awesome. Okay. Questions up to now? Pretty straightforward still? Yeah. All right. Laboratory findings. Obviously, you guys have seen the original Superman, right? When he comes to Earth in that weird, crazy spaceship. If that thing is ripping through your GU tract, then it's going to cause some bleeding usually, all right? And if you haven't seen the original Superman, look it up. Christopher Reeve, best Superman. No big deal. Anyway, so. Hematuria likely. Why? Because it's tearing up the mucosa. But just because it's not present doesn't mean it's not a kidney stone. So don't use that. I've seen students and I've seen junior clinicians try. Oh well, he doesn't have any blood in the urine, so it can't be a stone. Well, yes, it can. All right. So don't let that fool you. Urine culture. We do need to make sure that this is not an infected stone. Again, even if it's not obstructed with a fever, if there's infection behind it. Because of the stasis of urine, let that pass, that becomes an emergency again. So just culture the urine just to make sure there's no infection that maybe is not clinically present yet. And leukocytosis, we want to make sure there's no infection, but there might be a white blood cell response, and we shouldn't be in the frank leukocytosis because there's going to be an inflammatory response, so we might expect a little pyuria. But leukocytosis might make us a little bit worried. And then again, BUN, creatinine, EGFR, why? Kidney function. We want to make sure the kidney is functioning, right? One of the sequelae of this could be hydronephrosis. If we are starting to see, what is the term for this? If we have an obstruction to our urinary outflow, remember? Post-renal obstructive uropathy, right? Yeah, that's what we want to rule out. We want to make sure we don't have that, because if we do, then that might lead us to make an earlier referral to get the stone out to salvage renal function, especially if we have somebody who's comorbid or has existing kidney disease, okay? And as you alluded to, and you're absolutely correct, stone strainer, if we can get the patient to capture the stone, put it in a bag, bring it back, they can send it to the lab, crush it up, tell us exactly what it is. It makes it easier then for the treatment, okay? Because we know exactly what we're addressing. And here you go. In this case, gold standard is the answer. Non-contrast CT. KUV if you don't have anything else, but again, it walks like a stone, looks like a stone, okay, probably, your history should be sufficient, your history physical evidence should be sufficient. If you find yourself in a place where you can't get anything other than a KUB, then get it, but you don't need to get a KUB if you're if you're a BAMC, you don't need to get a KUB first and then get a CT scan, because that's what you need. Right. Ultrasound, like I said, focus, it'll find a shadow, so you should be able to see it. But again, still use it as an adjunct, but not as the answer, at least not yet. All right. Okay, now we're going to look at treatment. You guys still with me? Everybody okay? All right. We'll start with this one, number one. Asymptomatic and no infections, right? So how do we find this one? Incidentally / accidentally, right? We were looking for something else. There's a stone burden. Patient has never experienced kidney stone, or at least is not experiencing any symptoms now. We don't need to go follow them up in general, unless we have some established renal disease like MSK or something like that. Normal patient, we just find a kidney stone. Hey, there's a kidney stone in there, but we don't need to do anything about it because the risks outweigh the benefits, all right? If it starts to move, let us know. Most patients can be outpatient, all right? If it's less than 5 millimeters, between 5 and 10, all right, this is important. AUA guidelines recommend, and I'm gonna stress recommend, that a stone that's less than 10 millimeters be given medical treatment and close follow-up before we refer immediately. So it doesn't warrant an immediate referral, even though I'll tell you anything bigger than 5 is not really likely to come out on its own. But even the non-invasive procedures are not without their risks, okay? So the risk-benefit analysis is see if we can get it out with medical therapy and then take it from there. This chart, don't commit this to memory. These are not rock solid numbers. It just sort of paints the picture of the bigger the kidney stone and we get to about that 6 millimeter mark, the more likely there's going to have to be some sort of intervention to get it, right? Ureteroscopy, shockwave lithotripsy, whatever, okay? But don't worry about like trying to put those, I'm not going to, that's just for illustration purposes of the point. General treatment measures, hydration, okay? Hydration, they need to drink water. This isn't going to, it's probably going to pass over the course of days or weeks. Some unfortunate souls, months, depending on how long they can handle it. But analgesics, we can use NSAIDs if we need to. Toradol, a lot of times in the urgent care emergency setting will help. But this is a patient where you would be a little bit more likely to lean towards narcotic pain control. Because the patient's got to sleep, they've got to function, okay, until this thing comes out. Antiemetics, because if you're in that much pain and the nerves in the abdomen are becoming irritated, a lot of times nausea is a pain response, as you well know. So if they need it, more likely Zofran than promethazine, because phenergan will make them sleepy. It's sold narcotics, so. And then medical expulsive therapy. So, our alpha blockers, alpha-1 alpha selective blockers, right? Like Flomax, Uroxetrol, or the trade names, Tamsulosin, brand name, or generic name, excuse me. So essentially what it does, relax the smooth muscle in the GU tract, opens the passageways up a little bit, helps it move out, all right? So even though most of what we talk about them for on this side is going to be prostate stuff, those are the medicines that help patients go urinate for the exact same reason, because they open up the GU tract and relax that smooth muscle. In this case, they will help our patients sort of move that stone along, okay? So they should be first-line agents that you would use for these patients. Now, anything on this list of something that you would need to admit might not make any sense, right? We could just create this list off the side. You know, if we have evidence of obstructive uropathy, if we have a stone that's greater than 10 millimeters, so we know epidemiologically it's unlikely to pass, so we're not going to send this patient home with something that potentially could cause them to become anuric, right? If we have pain that we can't control with the meds that we give them in the ER, if we have a patient who's vomiting so severely that they can't tolerate PO intake, right? All of this stuff should make sense, right? Hopefully, yes. Okay. And again, this is the big one, you guys. If the patient has signs of infection and it is a kidney stone, essentially what we have is a mechanism for an abscess that's forming in the ureter going up to the kidney, all right? So that stone needs to come out now, which means that's not a consult to urology for later, that is a call to urology. Come down and take this patient because you need to take them up to the suite and pull that stone out somehow. Does that make sense? All right. So some treatments, I don't need you guys to know, like, I'm going to just go over this very generally. So shockwave lithotripsy, they put them in a water tank, give them some conscious sedation, and blast them with sound waves, and it turns the big rocks into littler rocks and gravel. Most of the time before this is done, they'll put in a stent to help facilitate that passage out. Right? And whether the stent stays in or not is up to the urologist, but it breaks up. So this is a technically non-invasive procedure, but it is not without risks. All right? And it is not completely painless, but it's pretty much the standard for somebody with kidney stones, okay? Or most of the people, okay? This is the stent I was telling you about. These can they can be utilized either in conjunction with or in preparation for, I should say, the lithotripsy procedure, or just as a procedure in and of themselves. Like I said, they might stay in afterwards, and it's just a stent. Like it just helps open up the ureters, and if they have stones, they tumble out easy. Okay. You can go in and grab the stone, all right, with a ureteroscope. And no, you don't just go in and grab the stone that's too big to pass and like pull it out really hard. They have lasers at the end of them and other sound waves that can break up the stone, and then they take out the smaller pieces. Okay. I had somebody ask me that before, so if the stone's too big to pass, they just go up and grab it, and then what? Well, they just yank it, obviously. No, because you can break it up. See, I mean, it's sort of see the picture. You can break the things up. And then a little basket extractor takes out the smaller pieces, all right, so that are facilitated the pass. This would be something that would happen. This would be most likely what would happen if you have one of those infected stones, right? Go up, get it out. Remember ERCP for choledochal, right? Go in, has a little grasper, grab the stone, pull it out. Similar physiology as far as like pus behind a stone, right? Pus behind an obstruction. Right? Percutaneous, more common than you think, for bigger stones or a bigger burden of stones. Okay, so again, not an open procedure yet, but more and definitely invasive. And then you have open nephrolithotomy. Go back to that picture of those staghorn calculi. Obviously, there's really no other way to get that thing out. So they flay the kidney open and pop it out. All right. We're actually almost done, y'all. So you guys are doing good. So bottom line, fluids, pain control, medical expulsive therapy. That's the bottom line for us. If we need to admit them, admit them. And be judicious. If they're in not much pain, just keep them in the hospital. It won't be your problem anyway, it'll be family practice problem. All right? And make your appropriate referrals and consults depending on the patient. Straightforward enough up to now? Okay, now let's talk about our poor souls who have these on a regular basis, unfortunately. Right? And it is a quality of life issue. And I talk about quality of life issues all the time. Does this happen? Has anybody ever had the pleasure of a kidney stone in here that wants to share? Yeah? No big deal?
No, I just passed it on.
Marines, man. Boom! What the hell is that? What's up? Yeah, you too? Yeah?
After AIT,
Yeah?
like a month after I got home, it was rough.
Was it awesome?
It was horrible.
I know. It's terrible. Yeah, it's no fun. No fun at all. But, so you can empathize with your patients that come to you. And you can understand what I mean. Imagine that happening all 2, 3, 4 times a year. It's no good, right? Right? So, stone composition, big thing. We need to catch one of these stones if we can, so we can see exactly what's going on. Now, obviously, we're going to default that this is more likely a calcium oxalate stone, and it usually is, unless that patient has a history of gout, or they have a history of UTIs, or they have that weird cysteine disease, right? It's almost always going to be calcium oxalate, but again, getting it and knowing exactly what the composition is helps us dial in the treatment that can reduce the overall stone burden and formation for these patients, okay? 24-hour urine, remember we talked about how it's not the greatest as far as patient compliance, but you'd be surprised how compliant patients get when they're in constant pain because of kidney stones. So we really need to see how much urine are you producing, and we need to quantify with a more precision than those spot quantifications like the UICR and UPCRs. Quantify literally exactly how much of these things you are producing on a daily basis. So again, we know, are you an overproducer of A, or underproducer of B, combo? It helps us, again, dial in our treatment. And then these come in pretty handy for us. We want to see what their calcium and phosphorus levels look like, what their uric acid is, okay? Obviously, BUN and creatinine, we want to know what their kidney function is. That should go without saying, I hope. But again, you want to just identify if they have an overabundance in serum of any of these things as well. And don't forget about our friend hyperparathyroidism, right? Always have sort of that in the back of your mind if you have a chronic stone form with no obvious explanation, okay? So, water. Drink water, okay? Now, if we have hypercalciuria, all the way back to the beginning. Thiazide diuretics. Now, what is that going to do to the patient? You might say that's a double-edged sword. We're going to diurese this patient. How can they overcome the diuresis effect? Go back to step number 1. Rule 1, drink more water. Rule 2, see through rule number 1, right? Yes, drink more water. And it's exactly that easy. And we have to emphasize that with our patients. But if they have an overabundance of calcium in the urine and they just continue to form these calcium stones, thiazide diuretics help keep calcium out of the urine. And so we reduce that substrate and we reduce the stone formation, okay? So it may seem counterintuitive to put a stone former on a diuretic, but that's the mechanism of why, okay? And again, low urinary citrate, you can have them intake more citrus juice along with their water, but we typically put them on potassium citrate, prescribed potassium citrate supplement. And then again, what does the citrate do? It inhibits stone formation, so we're giving them something that's going to help them prevent stone formation, all right? Do we have to do all of these things for every single patient? No. These are tailored to our chronic stone formers. Most likely what you're going to see is the top 2. Always the water, no matter what kind of stone they're forming, always water. And then most likely you're going to give that thiazide diuretic. All right, now, hyperoxaluria. What is that? Too much oxalate in the urine. How do we find that? 24-hour urine and metabolic stone evaluation, okay? There are dietary measures, and I have something at the end. All you have to remember about dietary measures is that they exist, and that there are things that you just Google low oxalate diet if you have a patient that has these kinds of kidney stones. And if you get lost and you can't remember, what can you do? Refer them to a nutritionist to give them like one-on-one counseling about how to reduce their stone burden through low oxalate diet. All right? Because it's one thing to tell a patient to Google low oxalate diet. It's another thing to give them a sheet that they'll throw away on the way out of the clinic. It's a third thing to actually give them an appointment and sit down face to face with somebody for some one-on-one counseling. All right? Now this may be counterintuitive. They have calcium oxalate stones. Why are we going to give them calcium supplementation? I already said it. I don't know if anybody's listening to that.
To reduce your body's absorption.
Huh?
To reduce your body's absorption of oxalate in the intestine. Because it's binding to calcium.
Close. He said to reduce your body's binding of calcium in the intestine. And it's actually to increase your body's absorption of calcium in the intestine. So, calcium is in the gut, oxalate is in the gut, oxalate is a metabolic end product. If you can get that calcium to bind with the oxalate in the gut and increase that absorption, then it'll go out in the feces. If you have not enough calcium in the system, in the gut, then you have an overabundance of oxalate that then gets reabsorbed and makes its way into the urine. Does that make sense? So it's you're almost there, but just a little bit different. Does everybody understand? So if you give this person a low calcium diet, because intuitively you think if it's a calcium stone, it's a calcium problem. What happens is they have less calcium available in the gut to bind with oxalate. Then that excess oxalate makes its way into the pee where it forms stones. Does that make sense? It's an important concept, all right? It's an important concept because people will intuitively think, I have a kidney stone, I Googled it, it's probably made of calcium, so I went on a dairy-free diet, I don't take any calcium anymore. That is actually making the problem worse, okay? Does that make sense? And don't feel like I said, these patients will come to you having tried things on their own, and if they just see calcium, then they think it's a problem, they'll stop taking the calcium. Right? Now, do you have to go to an overabundance of calcium supplementation? Not necessarily. The normal RDA is fine if they're just getting the normal calcium concentration through the diet. That should be fine. Maybe a little over-the-counter supplementation is fine, but they don't really need to like go to the extreme of getting way too much calcium. Does that make sense? So, and then we'll talk about our. I'm almost done, so I'm just going to finish this up, and then you guys can go. All right? So. Shake it off real fast. We're almost done. Hyperuricosuria, so our gout patients, you guys remember probenecid versus allopurinol, like our overexcretors versus our underproducers, right? So each of these meds addresses a different part of that, right? So if you have an overexcretor, that's going to treat how these patients are. They're excreting too much uric acid into the urine, so we're more likely to form these uric acid stones. So allopurinol will help with that, right? Help reduce uric acid excretion into the urine. If you give somebody probenecid, it actually increases. So probenecid we give to the overproducers to help them excrete more uric acid. But then that's making the problem worse because the uric acid is going into the urine and causing more uric acid stones. Bottom line of everything I just said, allopurinol yes, probenecid no. Okay? All right. Does that make sense though? Okay. Now we get to the hard stuff. Besides drinking water, we get to the real hard things, right? Which is fix your diet. Right? Nobody wants to do that. Yet another reason maybe to send these patients to a nutritionist so we can get it through their thick skull. But again, pain, this sounds weird to say, pain is on your side in this case, because again, patient compliance goes up when they're in chronic pain. Right? So hey, if you reduce animal protein intake, go to more plant-based protein. If you reduce your overall sodium burden and drink more water. We're not talking, you don't have to become vegan, all right? But just sort of reduce your animal protein intake. You can help with this, okay? So think about deployment, right? Everybody's got to get jacked in the desert, right? Nobody drinks water. Everybody's chronically dehydrated. Everybody's on whey protein, all kinds of other weird shit, right? And so you think kidney stones are a problem over there? Yeah, real big problem. And then somebody becomes, potentially combat ineffective because it's hard to do a mission when you're constantly doing this. And then we can see it's right there. Anyway, so I already gave this away. I used to wait until the end, but now I get too excited about the whole calcium metabolism thing, guys. All right. Plus, nobody gets the Anchorman reference anymore. So, more and more disappointing. So anyway, low calcium diets are bad. Your patients will probably come to you having tried them or currently trying them. Give them the education. Tell them that they're doing worse, more harm than good. Okay. I'm not going to say this again, but if anybody can't remember or is not listening, this is the mechanism of why we want to keep them with calcium-rich diets rather than calcium-poor diets. Bran, again, surprisingly, bran does a lot of things, but if you increase bran, it actually helps with pull more water into the stool. It helps actually reduce the calcium burden overall. It helps excrete some more calcium in the feces, so just getting rid of more calcium that way. Sodas are high in phosphate. I don't know. So Coke can take paint off your car, so it's not good for your kidneys either. And then avoid vitamin C supplementation, which you absolutely just love the taste. Again, you don't have to know this. Just remember the one thing I want in your memory banks when you think kidney stones, think oxalate, and know that there are low oxalate diets. People can eliminate things that are rich in oxalate from their diet and help reduce the thing that causes stones to form. Okay? Subtle thing. Again, lifestyle strategies is one of the hardest things to get patients to do, but it's one of the most impactful things that they can do for themselves. And then chronic stone formers, if we're doing good for them, all those labs we talked about, the 24-hour studies, if they have another stone, reassess to see if our interventions are working, right? And then do another stone analysis if they're not. And of course, at this point, if they haven't already seen urology or nephrology, they should. But not. Let me just leave you with this bottom bullet. You don't need to give every patient who has chronic kidney stones a yearly CT. That's not indicated. That's if a patient has recurrent stones and they keep coming back, checking for obstruction, things like that. It's just individualized by the patient. Do they need studies on a regular basis or not? Does that make sense? So the indication is not to give everybody with chronic stones yearly CT scans. Here is an algorithm for you, and here is a picture. Yeah. Anybody have any questions? It's the Rolling Stones.